الكل دخل ولا نستنى ولا we can proceed؟
براحتك دكتور، العدد كويس نسبيا.
اليوم راح نحكي عن الأوفيريان نيوبلازم، وراح نقسم talk about at the beginning we'll talk about the non-neoplastic functional cysts. Then we'll talk about primary ovarian neoplasm, whether they are benign or malignant. Is everything clear now؟ يعني سلايدات والصوت واضح؟
دكتور.
Okay. So we start with the non-neoplastic or the functional cyst. As you know, from the name, the functional cysts are related to the function of the ovary. These are cysts which develop in relation to the function of the ovary. Now, there are two main functions for the ovary, the production of ovum or eggs and the production of hormones. Now, when the girl or when the lady had her menstrual cycle started, when she started bleeding, what happened in the ovary, there will be a recruitment of follicles and preparing for the next cycle. Now, with time, most of these follicles, they become atretic, they disappear, or only one follicle will become the dominant follicle. And that dominant follicle usually grows until the time of ovulation. Now, sometimes for reasons, different reasons, that dominant follicle doesn't rupture at the time of ovulation, and it persists like a cyst, and this is why we call it the follicular cyst, because it is a dominant follicle. Now, these cysts are usually small in size, usually about 5 centimeters. They contain clear fluid, so they are thin wall, clear fluid content, simple cysts. We call them the simple cysts. Most of these cysts are asymptomatic and they are discovered accidentally. Yani the woman will have a scan, ultrasound scan for other reasons, and by chance we will find that there's a follicular cyst. Now, most of these cysts, they disappear spontaneously. So what we do is we rescan them again. We ask for another scan after the next menstrual cycle in a 4 weeks time. And the only time we need to interfere with these cysts is if they enlarge in size, they become bigger, or if they become asymptomatic. If they become symptomatic, yani the patient starts complaining of pain. In that case, we will consider surgical removal of the cyst only, and that can be done either by open surgery or by the laparoscope. Now, suppose that the dominant follicle did ovulate and release the ovum. Now, what will form on that follicle is what we call the corpus luteum. Now, the corpus luteum usually lasts for 14 days. This is the half-life of the corpus luteum. And this is why the luteal phase of the menstrual cycle is fixed at 14 days. Now, at the time of ovulation, sometimes an excessive bleeding might occur to the corpus luteum, yani more than the usual. So that corpus luteum will become filled with blood, and this is what we call the corpus luteal cyst. Now, because there is a bleeding into the cyst, the patient will usually complain of pain, and the corpus luteal cyst usually lasts longer than 14 days, and therefore it keeps maintaining the endometrium, and therefore the next period will be delayed. Now, when the next period comes, it's usually heavier than usual because the endometrium is thicker. Most of these cysts will require surgical removal because the patient is usually symptomatic. The patient will complain of pain because of the bleeding. So we usually have to remove these cysts. And again, we can do it laparoscopically or laparotomy. Now, the other function of the ovary is hormonal secretion. And as you know, hormonal secretion of estrogen and progesterone from the ovary usually happens from the granulose and thecal lutein cells. So there are granulose and theca cells in the ovary, and these respond to the FSH and LH from the pituitary, and they secrete the hormones. In certain situations, there will be hyperplasia and hypertrophy of these granulose and theca cells, and they form what we call the granulose thecal lutein cyst. And these scenarios can happen in hydatidiform mole pregnancy because of the high level of the beta-HCG, which shares some effect of FSH and LH, or sometimes during the IVF treatment, because we give exogenous FSH and LH as injections to the patient, and therefore sometimes the ovary will overstimulate, respond more than usual, and will form multiple cysts, and these are called the granulose thecal lutein cyst. And associated with that will be ascites and pleural effusion, and this is what we call the hyperstimulation syndrome. Now, the treatment of these cysts is simply treating the underlying cause. So if we treat molar pregnancy, or if we stop the exogenous FSH, these cysts will disappear spontaneously. So these are the functional cysts اللي هم related to the functions of the ovary. Okay? Is that clear? يا عامر؟
دكتور.
Now, نيجي للclassification of primary ovarian tumors. And these could be benign or malignant. Now, the ovary is made up of 3 types of cells. There are 3 types of cells in the ovary. We have the epithelial cells, which are covering the surface of the ovary. There are germ cells in the center, which produce the eggs. And we have the stromal cells, or the 6 cord cells, which are containing the hormonal secreting cells, or the fibroblasts and collagen, which is supporting the structure of the ovary. So based on the cell of the origin for the tumor, we classify them into epithelial tumors, germ cell tumor, or 6 cord tumors. So if the cell of origin is the epithelium, we call it epithelial ovarian tumors. If it's germ cells, we call it germ cell tumors, and so on. And each one of them can be benign or malignant. Now, let's talk about the germ cell tumor. The benign germ cell tumor, the commonest benign germ cell tumor, is what we call the benign cystic teratoma, or the dermoid cyst. And I'm sure you are familiar with this term. This is probably the most common ovarian tumor in young women in the 20s and 30s. This cyst will contain tissues which are derived from the 3 germ cell lines. Yani you will have cells from endoderm, ectoderm, and mesoderm. So in the cyst, you might find hair, follicles, sebum. You can find bone and teeth, stomach tissue, thyroid tissue, and nerve tissue. All types of tissues can be present in these cysts. These are benign cysts. They can be bilateral in good proportion of patients. And malignancy is very rare in them, and malignant changes can occur in one of the components only. Now, this type of cysts, they do not disappear spontaneously. They don't disappear. So therefore, they have to be removed surgically. So this is the commonest benign tumor. This is an example of dermoid cyst. You can see it like filled up with sebum and hair. There is sebum hair here in this type of cyst. Now, what about the malignant germ cell tumors? These are very rare tumors. They account for only 1% of all ovarian cancers. The characteristic thing about them, they tend to occur in young age group. So most of the patients are below the age of 20. The other thing that they respond very well to chemotherapy. And the other thing is each of these tumors is having a specific tumor marker, which was very helpful in the diagnosis. So you will have a young girl with a solid ovarian mass, and you send the tumor markers, you can easily find the histological type. So the histological type are the solid teratoma in comparison to the cystic teratoma, which is benign. The other type is the non-gestational choriocarcinoma, and the tumor marker is the HCG. And they call it non-gestational choriocarcinoma to differentiate it from the choriocarcinoma, which follows the molar pregnancy. The third type is the yolk sac or the endodermal sinus tumor. And the tumor marker for this is the alpha-fetoprotein. The commonest malignant germ cell tumor is what we call the Germinoma, which is similar to the seminoma in the testicles in males. So this Germinoma is the most common malignant germ tumor of the ovary. This is a highly malignant tumor. Usually it's spread by the lymphatics, and it's very radiosensitive. Again, this Germinoma can occur in women with abnormal gonads or gonadal dysgenesis, and particularly patients with Turner syndrome, because they have streak ovaries. So they are liable to develop this Germinoma. Because these tumors occur in young age group, their treatment is really important because we need to do conservative surgery. So we just remove the affected ovary, and after that we give them chemotherapy. And usually they respond very well to chemotherapy, and the prognosis is usually excellent, even in the advanced stages. So they respond very well. This is what you really need to know about the management of these tumors. They are rare tumors. The 6 core tumors, or the mesenchymal tumors, example is the granulosa cell tumor. Now, do not mix between the granulosa theca cell tumor and the granulosa theca lutein cyst. These are benign cysts, and the granulosa tumor is malignant. This is a large solid, usually. It can occur at any age group. It can occur in young age group, middle age, and old age group. Characteristically, it secretes estrogen, and therefore usually the presentation is hormonal manifestation. So if the tumor happens in young age group, and because it secretes estrogen, they usually present with precocious puberty. In the middle age group, usually it secretes estrogen, and the patient will present with menorrhagia. In postmenopausal women, the secreted estrogen from this tumor will act on the endometrium and can predispose endometrial hyperplasia and endometrial carcinoma. And therefore, the patient usually presents with postmenopausal bleeding. The other thing about them, because of the hormonal manifestation, they are usually diagnosed in stage 1, so in early stages, and their treatment is basically surgical. Chemotherapy and radiotherapy is only cases and advanced cases. Characteristically, also, they tend to have a late recurrence, which can happen after so many years of the initial diagnosis. Another example of the androgen secreting tumor, we have the androgen secreting tumors like androblastoma or sertoli Leydig tumors of the ovary. These are rare tumors and usually present with virilization. So suddenly the patient will have amenorrhea, so they stop having menstrual cycle. They will have acne, hirsutism, deepening of the voice, breast atrophy, and in that case you need to suspect an androgen secreting tumor of the ovary. Fibroma is basically a solid tumor of fibrous tissue. It's only fibrous tissue, so this is a benign tumor. They tend to have a long pedicle attaching them to the ovary, and therefore they are liable for torsion. It might be associated with the fibroma. They might be associated with pleural effusion and ascites, and this is what we call the Meg syndrome. So Meg syndrome is a combination of ovarian fibroma and ascites and pleural effusion. If it is only ascites and fibroma, we call it Pseudomeg syndrome. In fact, yesterday I operated on a patient with the Pseudomeg syndrome. Krockenberg tumors, it is metastatic tumors, secondary tumors of the ovary, usually arising from the stomach and colon. It can be from the breast, so they are metastatic tumors. And
دكتور 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 حد سامع صوت الدكتور؟
لا.
طيب ماشي.
الو
دكتور قطع صوتك.
ليه؟ السلايدات راحوا ليش؟
ليش السادات راحوا؟ دكتور اكبس على اسم من الاسماء اللي تحت موجودين عندك، اللي موجودين as initials، بعدين بيطلع لك على اليمين كمان تحت، ساعتها بيطلع لك زي صورة الباوربوينت، ترجع تكبس على الباوربوينت تقدر ترجع تطلع.
لا خلاص رجعوا هسه رجعوا السلايدات، بس ليش راحوا يعني؟
بجوز قطع النت دكتور.
اوكي يا عامر. Are we back?
Yes, doctor.
Okay. So this is a summary of these tumor markers and their cancers. Just add the CA125. This is the tumor marker for epithelial ovarian cancer, and you have to pay attention that this can be elevated in some benign condition, like fibroids, endometriosis, pelvic inflammatory disease, and so on. So other benign condition, but usually the elevation is mild. However, in cancers, it will be highly elevated. The cut limit for this CA125 is 35 units per deciliter, and therefore in cancer patients sometimes you will find it in thousands. Complication of the ovarian tumors, whether benign, malignant, or cyst, they can undergo torsion, they can rupture, hemorrhage, impaction, or infection. And usually the complicated ovarian tumor usually present with acute abdomen. And the presentation will be similar to acute appendicitis. Now, talking about the commonest type of of the ovarian tumor is the epithelial tumors. These are the common types, and there are several histopathological types like serous, mucinous, endometrioid. They can be clear cell types or Brenner tumor. So different histopathological groups. And that can be both benign and malignant. So you can call it serous cyst adenoma for the benign, or serous adenocarcinoma for the malignant. Again, mucinous adenoma or mucinous carcinoma, endometrioid carcinoma. Sometimes you will find endometrioid carcinoma of the ovary with endometrial cancer as well. So in the same patient, you will find both endometrioid type of ovarian cancer and endometrial carcinoma. The mucinous type, usually they are large types of tumors. The tumor will be composed of multilocular cysts. There are multiple cysts within the big cyst, and they are filled with mucin, اللي هو gelatinous material. So if that cyst rupture, then the patient will have what we call it the pseudomeg peritoneal, where the whole peritoneal cavity will be filled with mucin. Serous type, it usually contains clear fluid. It's bilateral, can be bilateral, and very common around the age of menopause. Now, the Cellulose Carcinoma is the commonest type of ovarian cancer. As I mentioned, endometrioid, you can have it with endometrial cancer in the same patient in around 1/3 of the cases. Brenner tumor, this is a benign tumor, and histopathologically it resembles the bladder epithelium. So in the histology, it's very close to the bladder epithelium, and it might be associated or coexist with mucinous cyst adenoma. We have one entity called borderline tumor. So it's not benign and not malignant. We call it borderline tumors. So borderline tumors of the ovary are tumors which have some of the malignant features. They have abnormal mitosis, abnormal differentiation, but there is no invasion of the basement membrane. Most of these tumors are serous types, and usually they are diagnosed in early stages, and their prognosis is excellent. So the 10-year survival is around 95%, and their treatment is surgical. They don't respond to chemotherapy. But it's very important from a pathological point that the pathologist will do several sectioning to rule out invasion. Because if there is invasion, it's not a borderline tumor, it is an invasive tumor. Now, talking about the malignant epithelial ovarian tumors or the epithelial ovarian cancer, as you see, it's a group of histopathological types, serous, mucinous, endometrioid. By far, it's the worst prognosis among all the female genital cancers. It has a very high mortality. The 5-year survival is only around 30%. 30%. Every female have a lifetime risk of around 1% to develop ovarian cancer. And because the ovaries are in the pelvis and they are open to the peritoneal cavity, usually the method of spread is by direct spread. So they spread along the peritoneal surfaces into the liver, into the spleen, the bowel, the bladder, and so on. Lymphatic and bloodstream metastases are rare and usually tend to occur in advanced stages. Why women develop ovarian cancer or epithelial ovarian cancer? The risk factors include nulliparity or infertility, history of infertility, patients who are receiving the fertility drugs to get pregnant, especially if they are used for a long time, they are at higher risk of developing epithelial ovarian cancer. Around 10% of epithelial ovarian cancer, they run in families. So there is a family history, and that would be part of the BRCA1 gene mutation. So patient will have breast and ovarian cancer risk. On the contrary, the protective factors عكسهم تماما. So the number of pregnancies, the more patient is having pregnancy, the lower the risk. Patients who are taking the oral contraceptive pills for 5 years or so on, they will reduce their incidence of ovarian cancer by around 50%. And there are reports that tubal ligation offers some protection against ovarian cancer. Now, the bad news about ovarian cancer, that around 75% of the cases, they are diagnosed in advanced stages, usually stage 3 and 4. Now, the reason for that is because of the non-specific nature of the symptoms initially. So most of the patients initially will complain of non-specific abdominal pain, bloating sensation, they cannot eat very well, and they are usually diagnosed with gastritis or irritable bowel syndrome. And until at least 1 to 2 years after the symptoms, when they start to have ascites, pleural effusion, huge distension of the abdomen, where they are diagnosed as ovarian cancer. So as you can see in this graph, the majority of the patients are in stage 3 and stage 4. So تقريبا 75% are in stage 3 and 4. This is how would you see patients with ovarian cancer: huge abdominal distension, huge ascites. You will have masses in the pelvis with different sizes and shapes. As you can see here, these are solid ovarian tumors. You can have the omentum, which is infiltrated by the tumor, and it's converted into a solid mass. And this is what we call the omental cake. After the diagnosis or suspicion of ovarian cancer, مثلا جاتك مريضة في العيادة and you are suspecting ovarian cancer, so what you will do is you send them ultrasound of the pelvis and CT scan of the abdomen and pelvis to see if there are any evidence of metastasis. Then you send the tumor marker panel, which might be helpful to know the type. You send kidney function and liver function and chest X-ray. And after that, you can simply calculate what we call the risk malignancy index. So what is risk malignancy index? Risk malignancy index is simply a very easy way to know whether this mass or this tumor is benign or malignant. Basically, what you do is you have the CA125 level, which is a lab result. So you enter it in the equation. Then you multiply it by the menopausal status. So it's not the age, it's the menopausal status. If the patient is pre-menopause, you give her a score of 1. If she is post-menopause, you give her a score of 3. So the patient will have a score of 1 or 3, depending on her menopausal status. Then you look at the ultrasound report. And in the ultrasound report, you have 5 points which are really of importance. Is it unilocular or multilocular? Is there any solid areas? Are they bilateral? Is there any ascites or evidence of metastasis, intra-abdominal metastasis? So these are the 5 points which are signs of malignancy. So if the patient is having only one of these features, you give them a score of 1. If there are 2 or more features, you give them a score of 3. And then you calculate the risk malignancy index. So a risk malignancy index will be simply C125 level, إجاك من المختبر 100 مثلا. You multiply it by 1 or 3 for the states, and you multiply it by 1 or 3 for the ultrasound. So at the end, you will have a figure. So suppose it's 100, and she's postmenopause, so 100 في 3 300 في 3 900. Now the cut limit for the risk malignancy index is 200. Anything above 200 is malignant. Anything below 200 is benign. This is the staging. is مش مطلوب منك الstaging. Now the management of epithelial ovarian cancer is basically 2 steps: surgery and chemotherapy, both of them. Now, extremely rarely, in very few selected patients, you can do surgery alone. اللي هم يعني the tumor is early stage and it's confined to one ovary. In that case, you can do surgery alone. But if our patient will require both surgery and chemotherapy. Now, which is first? Do you start with surgery or you start with chemotherapy? Both of them are applicable. يعني عندك 2 options with regarding to the surgery. So either you go with a primary surgery. So patient after diagnosis will go to theater and you do midline laparotomy, you remove the uterus and the both ovaries and tubes, you do omentectomy, you do peritoneal washing, and basically what you are trying to achieve with this surgery is to remove any gross tumor. So there is no residual tumor at the end of the surgery. That's the aim. After you achieve this surgery, you start the chemotherapy.
Okay. دكتور
Yeah, Bishar.
بدي أسألك أنا عن الترتيب هلا مش في like we start with chemo then we go surgery then we go back to chemo so we can هيك نصغر التيومر to be easier in the theater ولا لا؟
Bishar. Now, alternatively, you can do what we call the interval debulking surgery, which is alternative to the primary surgery. And in that case, sometimes you might have patients who are medically unfit and عندهم comorbidities who you need time for theater or the large ascites or nutrition. And in those cases, what you do, after you confirm the diagnosis, you give them 3 cycles of chemotherapy. And after after the 3 cycles of chemotherapy, hopefully you have the time now to make them fit for surgery, and you shrink the size of the tumor. You do the surgery, 4 cycles of chemotherapy. And the aim for this is that you improve the patient condition, and so they can tolerate surgery very better. And at the same time, you can increase the ability to remove the tumor. So positive. With regard to chemotherapy, عامر عامر او روان واحد يرد علي.
معاك دكتور.
مين هذا بشر؟ مين بشر؟
بشر واحد معنا بالدفعة. بشر رد على الدكتور.
دكتور
ظل يفتح المايك
هيو هسه سكر
يحكي ايش يبغى.
هو سألك سؤال دكتور انه احنا ما بنعطي ثيرابي قبل السيرجري وبعد السيرجري.
ما حكينا هاي قبل شوي كنا
تمام
نحكي عنها.
تمام.
يعني you have two options. Either you go with the surgery first and then you cycles, or you give 3 cycles of chemotherapy at the beginning, then surgery, then you give 3 more cycles of chemotherapy. So there are 2 approaches. With regard to the chemotherapy, as I said, chemotherapy is needed in all cases ما عدا الحالات اللي هم very early, which is confined to the tumor. Basically, we're giving platinum and Taxol chemotherapy. مش مهم تفاصيله. Generally speaking, we give 6 cycles of chemotherapy at 3 weekly intervals. So it's 6 cycles of chemotherapy بيناتهم بين كل cycle والثاني 3 أسابيع. And during the treatment, we monitor them clinically and by the CA-125 level. The response is really very well to the treatment. The response is usually good. However, يعني, although it's advanced tumor, after the surgery and the chemotherapy, most of the patients go into clinical remission. They will be cured. حوالي 80%. المشكلة فيهم إنه عندنا high recurrence rate. والrecurrence rate usually happen in the first 2 years of the treatment. And once it is recurrent disease, it's becoming extremely difficult to treat it. It's very difficult to treat it, and it's becoming resistant to chemotherapy. So here, if you look at the survival by stage, the 5 years survival for stage 1 is very high. It's around 90%, which goes down to 10% or 20% in stage 3 and 4. But our patient, majority of our patients are in this group. This is why the 5-year survival for all patients is around 30%. Now, after we finish it, we follow 3 months for the first year, then after that 6 monthly. And the follow-up is usually examination and tumor marker, CA-125 level. If the CA-125 level starts elevate again during the follow-up, that will indicate recurrence. And in that case, we have to do imaging in form of CT scan to check up for recurrence. What happened during pregnancy is that sometimes we are faced with a pregnant patient with ovarian cyst. يعني الست بتجي على العيادة for pregnancy check, and you discover that she had an ovarian cyst or ovarian tumor. Now, most of these tumors and cysts are benign. Either they are corpus luteum or dermoid. Very few percentage of them are malignant. يعني less than 2% are malignant. So how do we manage them? The management in the first trimester, what we do nothing, basically. We just observe it, hoping that this is a benign cyst and the corpus luteal cyst, which will disappear spontaneously. Plus, that the risk of operation during the first trimester is high. There's higher risk of miscarriage, يعني inducing abortion or miscarriage. So in the first trimester, we do nothing. We bring the patient back in the second trimester and we do another scan, ultrasound scan. If the cyst persists, then we operate them on the second trimester. طبعا it goes without saying that if the cyst is becoming complicated, or the patient is complaining of acute abdomen, that in that case you have to operate immediately. The last thing about ovarian tumors is حكينا في البداية إنه lifetime risk للovarian cancer is around 1%. يعني every female will have a 1% risk of developing ovarian cancer. And we have said that 5 to 10% of ovarian tumors are familial or genetic. So if the woman has one first-degree relative affected by ovarian cancer, and her mother, her sister is affected, then her lifetime risk will increase from 1% to around 3%. If she has two first-degree relatives affected, then her risk will increase to around 13 to 15%. If she had two or more first-degree relatives, in that case, you have to suspect that they have the BRCA1 gene mutation. Now, if she is proven to have BRCA1 gene mutation, then her lifetime risk for breast cancer, for ovarian cancer, is around 50%. And her lifetime risk for breast cancer is around 70%. So BRCA1 mutation carriers, they have 50% risk of ovarian cancer, 70% risk of breast cancer. And this is what they call it recently, and they start calling it Angelina Jolie syndrome. إذا سمعتوا في الممثلة هاي اللي اسمها Angelina Jolie, she had mastectomy and oophorectomy prophylactically to reduce her risk of ovarian and epithelial cancer because she is BRCA1 carrier. So those patients اللي هم BRCA1 carriers, we advise them once they completed their family to have a prophylactic mastectomy and prophylactic oophorectomy. They have to have them removed. Now, because of the bad behavior of the ovarian cancer, there have been attempts to try to screen for ovarian cancer. And in the screening, we are faced with two main problems. The first thing is that there is no precancerous stage. It's not like cervical cancer, where there is a precancerous stage. Here, you will have a normal ovary, and after a month, you will have cancerous ovary. So you cannot detect the precancerous stage. Then people turn off to try to pick up the tumor in the stage 1, in the early stages, because it has a good prognosis. The other problem is we don't know the natural course of the disease, is unknown. So you will find a patient who is normal today, and after 6 months, she will have stage 3 or 4 ovarian cancer. So if you are planning to do screening, how frequent you have to do it. However, now there is no recommendation for screening in the general population, but we can use a combination of the tumor marker CA125 level and the ultrasound, transvaginal ultrasound, on a yearly basis. And we can use it only in high risk group patient, البيشنت اللي عندهم مثلا strong family history. هذول المرضى they might benefit from these yearly ultrasound and the CA125 level. Okay.
تمام.
Any question?